tissue risk, not a historical risk, not a surrogate, but a real risk, had an 86% reduction in the breast cancer risk. Very dramatic. Now, it wasn't many patients, but it's still very dramatic, and it makes sense, biologic sense, because those lesions tend to be very estrogen positive. So it attracted my attention and made me think, well, gee, we ought to be really trying to figure out some way to find atypical hyperplasia to know that's the population we ought to be giving tamoxifen to. And I'll come back to that in a minute, because I thought I had these slides in a different order. This is the second model that is popular, that is becoming increasingly known. It's called the Klaus model, and I just show that complicated table to show it's not that complicated, but basically you plug in numbers and get out a risk. The key is that this is for women with strong family histories. It's better than the Gale model if you're dealing with family history, because it takes in first and second degree relatives, maternal and paternal relatives, and most importantly, it counts the age of your relatives when they got cancer as a risk factor and takes that into account, which the Gale doesn't. So we kind of have two major options when you're doing a risk assessment, either the Gale model, or if it's a more complicated family history, the Klaus tables, that's better for identifying women that might have one of the breast cancer genes. There's an old-fashioned model. I've been doing this so long that I precede the Gale model. I had to do this before there was a model, and I was advised by a breast pathologist